biología de hoy, después del café, ya estarán bien entonados todos, así que hoy día tenemos otro presentador extraordinario, como ya lo gozaron la vez pasada en las presentaciones de trauma craneano, es el doctor Paul Parissel de Bélgica, y hoy día nos va a presentar Medir es saber, desarrollar biomarcadores cuantitativos para neuroresonancia. Quisiera pedir un favor, que si pueden poner sus teléfonos celulares en vibrador para no distraer. Gracias.
Muchas gracias por su amable introducción, profesor Del Carpio. Es un placer de estar aquí. Esta presentación es dividida en dos partes. La primera parte es más o menos teórica. Después, si tenemos tiempo, vamos a hacer algunos casos. ¿Ok? La primera presentación es teórica. Medir es saber. To measure is to know. And I call this developing quantitative MRI biomarkers in neuroimaging. And I would like to acknowledge my former PhD student, Wim van Hekke, who has helped me in this area and is very active. These are my disclosures. When we look at the aging brain, and we look at individuals from different ages, starting at a small baby until an aged person, we see that intuitively, we see that there is more water in the skull and that the volume of the brain is shrinking. This is one way of describing it. If we want to use biomarkers, we could do this in different ways. We could, for example, look at the volume of the brain, and we can do that now with relatively simple segmentation techniques and measure the volume. We could look at the MR spectroscopy to see how the biochemical composition of the brain is actually going to change. We could look at the perfusion of the brain, and we know that as we get older, the microperfusion of the brain becomes less. We could look at the parameter which was popular 20 years ago, is not so much anymore, magnetization transfer. We could look at relaxometry and actually measure T1 and T2 relaxation times. And we could look at diffusion imaging, diffusion-weighted imaging, diffusion tensor imaging. All of these techniques are giving us tools to describe this process in a quantitative fashion. And this is what we mean by quantitative MR imaging. Now, if we want to introduce this in clinical practice, we need to have a strategy and we need to understand what we are actually going to do. And I call this approach the ABC, and the 1, 2, 3 approach to introduce quantitative imaging biomarkers in neuroimaging. And these are my ABC. Why? What is the potential of imaging and imaging morphology? And then the 1, 2, 3, we will look at parameters for the whole brain, for a part of the brain, a regional analysis, or for an individual voxel. And let's start with why we like to have biomarkers in neuroscience. Why should we even bother? Why is this important? Well, when we try to quantify, because we know that there is an evolution towards what is called a personalized medicine. And personalized medicine is something that will require quantitative results. We are told that we need to do medicine on an evidence-based ground. We are developing clinical decision support tools and for this we need quantitative input. We need more and more, we are moving from paper for performance plans, and we need objective metrics to actually do that. So because of all these things, we feel intuitively that it is not good enough to describe in a liver that there is a big tumor. and that when we compare to a previous scan, that the tumor is, we are not sure if it's the same or a little bigger or a little changed. We need metrics to actually describe these changes. So a biomarker ideally should be accurate, should be objective, precise and reproducible, validated, sensitive. And in fact, when we think about what researchers are doing, and this is before the clinical application, researchers have been using biomarkers a lot of time. And we know this from the medical literature. If you open a good journal, like European Radiology or whatever, you see that there are quantitative results, there are statistics, there are tables, there are graphs. In the clinic, radiologists have always been a little bit distant. But we see that we are now approaching a time that even in clinical trials, in selected groups of patients, we are introducing this. And we are also moving to the introduction of this in clinical practice. And there is one area that we have a lot of experience in, which is multiple sclerosis. And I will show you this. The process of validation is all important. This is a patient with multiple sclerosis, and this is a translation from a typical report of the radiology. So the radiology tells us that there are multifocal lesions, multiple lesions, there is moderate global atrophy, and then the conclusion of the radiologist says that there are, again, multiple T2 hyperintense lesions. The clinician is not interested in that, because the clinician already knows that there are multiple T2 hyperintense lesions, because the clinician knows that the diagnosis is multiple sclerosis. And then the radiologist says there are no obvious major changes. You know, and pardon the expression, but what does that mean? You know, does it mean, are there changes? Are there no changes? What does it mean? And it is what we call, in my language, the radiologist is actually opening the umbrella to protect himself or herself so that whatever happens, you know, it's... So this is not accurate, this is not sensitive, this is not specific. Now, the real problem in multiple sclerosis is this. You have a baseline MRI, and then the patient, for example, is treated with medication, biologics, which are horrendously expensive. In my country, current treatment for patients with multiple sclerosis with these biologics is about 40,000 to 50,000 euros per year per patient. Incredibly expensive. And the task for the radiologist is to compare these two scans. Is it the same? And you start already with some problems, because maybe this is done on a 3 Tesla and this was on a 1.5 Tesla. Maybe here the slice thickness was 5 millimeters, maybe here it was 3 millimeters, or vice versa. Maybe the slice was a little bit different. Even when we do 2 planes, like a sagittal plane, is this the same or is it not the same? It's very, very difficult to tell. And this is exactly why we feel that we don't need to describe this in prose, but we need numbers. So let's focus now on the potential of imaging. Imaging has changed and is continually changing. We know that in the imaging trends, many of us in neuroradiology are now obtaining 3D data sets. We are scanning the entire brain and then reconstructing the brain in several directions. We know that we get information from translational science that we try to quantify by techniques which are called segmentation, and we know that we try to move beyond anatomy to look at microstructure. All of these things are new, or at least new since the last 10 years. We are no longer just taking a few slices and then looking at them and making a report. We are moving beyond that in our technical capabilities. And if the technical capabilities are improving, so does our reporting, and our analysis of the images has to improve. A paper I did a few years ago for the Journal of the American College of Radiology we looked at the kind of information we get, the technique, and the biomarker. If we look at anatomy, for example, we can use T1, T2, proton density, whatever, and we can look at the number of lesions. Structure, we look at typically with diffusion-weighted imaging and diffusion tensor imaging, and in the liver, you could also look at, for example, this shock wave, what is it called, relaxometry, or, yeah? The function, we have been using functional MRI or resting state fMRI since more than 20 years. Dynamics, we can use perfusion-weighted imaging, arterial spin labeling imaging, and we can look at vascularity, perfusion, capillary permeability of a lesion. And molecular, we could use either spectroscopy or PET, and we know something about the metabolism. Now, all of these informations together, to me, they look like a jigsaw puzzle. Each little part gives you a little bit more of the puzzle. And we try to do that in a way which is non-invasive, with different contrast, look in the brain, quantitative, and analyze the whole brain. And this is what we want in biomarkers. Now, imaging morphology has been always the core of what we do. It has been the mainstay, and basically morphology, we look at anatomy and ultrastructure, and these are the things we use for that. And anatomy, as I told you before, more and more in my department, for example, we are doing mostly 3D acquisition sequences. We are going towards volumetric acquisitions, and we reconstruct them as we see fit in different imaging planes. For the ultrastructure, we have been using for the last 15 years diffusion-weighted imaging, and more also diffusion tensor imaging, which gives you a look into the microscopy of a lesion. It gives you a look in the microcellular environment and the fibers, etc., in the structure, and we can make these very nice 3D maps that we can color according to the direction of the fibers. And you can, for example, identify the corticospinal tract here in blue that goes through the brainstem and into the spinal cord. You can also identify the cingulate fasciculus, the corpus callosum in red, and so on. So let's now move the 1, 2, 3. How can we actually implement this in practice? And let's start with the whole brain. The whole brain analysis, and I spoke yesterday about the trauma. The idea would be to have one number, like blood pressure is. Blood pressure is one number, or at least a systolic and a diastolic number, that gives you an idea about the integrity of the entire cardiovascular system. It's one number, and you can measure it today, and you can measure it next week, and you see the influence of medication. Do we have something for the whole brain? And the idea that I showed you yesterday in the trauma lecture was to use fractional anisotropy as one biomarker for the whole brain. So it is vision. Do we have one biomarker that would reflect the status of the entire brain? And we can actually do this by analyzing the anatomical information and by segmenting out different parts. For example, the gray matter, the cerebrospinal fluid, the white matter, and here is a 3D segmentation looking at the volume of the cerebrospinal fluid spaces. And we move from anatomy to structure. And this is an example of the same data set, how you can segment this. This is not rocket science. You don't have to be a genius to actually use a software program to do that. But you can see here very well in green the gray matter. You can see in red the cerebrospinal fluid. You can see in white the white matter. And you can actually get volumetric information about these structures. So coming back to our patient with multiple sclerosis, there are some white spots. Instead of simply looking at this and then generating a report and saying something like there is no major, significant, obvious change, we could actually feed this information into a computer and get back almost immediately something like this. And what we now see is in blue are the white matter lesions segmented out, and in green is the cortical gray matter. Because the current thinking in multiple sclerosis is that this is a disease that has two components. One is the inflammatory component. These are the white matter lesions, and they cause inflammation. And the other is the degenerative component, which causes loss of gray matter tissue. And medications have been developed to attack these two phenomena, and they are not the same. So what is important, if we are going to do that, is to actually know how good is the measurement. And we need to know that the measurement error is smaller than the effect that we hope to find. And here are data sets from a Philips scanner, from a Siemens scanner, and from a General Electric scanner, the same individual obtained in 2 time points. And with the software that we developed, we now know that we have a measurement error or a variation of about 0.13% to look for whole brain atrophy. And this is pretty good. This is very reproducible. This is validated software. There are publications about that. And older techniques like cross-sectional methods have an error that was much larger. So what I want to bring to you is the concept that instead of simply writing prose, we could do something like this. We could assess the white matter lesions, and we can measure the evolution from one scan to the next, and we can assess the volume of the brain and again compare the evolution. And we can play with the software to actually show new lesions, for example, in red. You can see here a new lesion. Enlarging lesions in purple, and stable lesions, which are the same in this greenish yellow. And the report that we generate is something like this. We compare the data set, and we compare 2 time points. There's a white dot and a black dot. And we also know the normal range for patients of that sex and that age and that population. And we can compare this. And we are coming closer now to blood pressure. Because when we measure blood pressure, we know that we have a standard range of what is considered normal for that age and that population. And we generate these reports automatically. And we can do more. And this is, for example, what I like most. Here you see that we have a number of scans where we look at the periventricular, and I have to put on my glasses because I can't see it, the periventricular, the juxtacortical, the infratentorial, and the deep white matter lesions. And we have different bars representing the different scans that this patient has undergone. And we can see, for example, that there is a slight increase in the periventricular, or a significant increase in the periventricular lesions over the scans. Also in the juxtacortical lesions. And basically in all the anatomic areas, there is a progression. And we can measure actually the volume of these lesions, and we can tell the neurologist exactly if there is a positive effect of the treatment or no effect of the treatment. This is the way I think structured reporting is going to go. Another example, we are doing a big project, as I told you yesterday, on head trauma. And one of the simplest and most important measures in a head trauma patient is the shift of the midline structures. We saw that there were huge variations because one radiologist measured this at the level of the third ventricle, another 1 centimeter lower or higher. One radiologist draws a line according to the folks. Another radiologist sort of draws a line from, based on skull reference points. There's a huge variation. And also this, something very simple, like shift in the midline structures, we can actually very accurately measure with biomarker analysis. This was whole brain measures. Now let's move to region analysis. There are certain diseases in the neurological system that we know are affecting more a specific area of the brain. And one of these areas, for example, is the hippocampus and the temporal lobe in patients with Alzheimer's disease. And we know that when we start with a whole brain, we can actually segment out the hippocampus, and we're going to make the brain transparent, and we're going to look inside at the hippocampus. And even in the hippocampus, through relatively simple segmentation techniques, we can identify the different parts, the different constituents of the hippocampus, and we can magnify them, we can take away the rest of the brain, and we can measure them, and we can obtain very accurate volumetric assessment. There was in radiology, I think last month, a paper showing prediction of the development of Alzheimer's disease based on hippocampal measurements, and we think that this is an idea. And again, we move from anatomy to structure. This is what I think. Voxel-based analysis is something that most radiologists are not really familiar with and that they are a little bit afraid of. And the idea would be to take one volumetric element, one small voxel in the brain, and do analysis on that voxel. And the idea would be to have one biomarker for each voxel. And the pipeline is called voxel-based morphometry. In the jargon, this is called VBM, voxel-based morphometry, where you actually start with the original diffusion tensor imaging data. You create an atlas, you compare this with registered data, and you measure voxel values, and then you do something which is known as voxel-wise statistics, and in that way you can actually look at a voxel. So we have the possibility now, we have the technical possibility to actually develop biomarkers for the whole brain, for a region of the brain, and for a voxel. The question is, do we have the willpower to actually force this, to force ourselves to do this? Now, I believe, and I strongly believe, that in radiology, we are living currently a paradigm shift. We are moving towards the individual patient. Most of what we do is based on studies in research where we have large groups of patients with a well-defined disease. You have a cohort of 1,000 patients with multiple sclerosis, and all the patients with vasculitis and Behçet's disease and whatever, they have already been taken out, so it's a very homogeneous population. Many are single center, some multi-center, and it's an experimental acquisition. But what we have to deal with is the individual patient, and this is a patient with heterogeneity of disease. We do not know in advance if the white spots in the brain are actually due to multiple sclerosis or vascular ischemic disease or Behçet's or some other kind of inflammation. We only have a limited time to do the study. We schedule patients every, 20 minutes or half an hour. We cannot spend 1 hour doing all the sequences, and we don't have really reference data. So we think that when we grow from groups to single subjects, we actually should have measurements, we should have analysis methods that are reliable, observer independent, and most of all, we need to be able to compare to a healthy group. We need to define what is normal and what is not normal, and we need to harmonize our protocols. We believe that, some people believe that there is a contradiction between the world of informatics and the world of radiologists. The world of the computer has this: objective measurements, handling large data, automated and centralized analysis. But the radiologist has something more. We have experience, we have expertise, we are trained to pick up something that is unusual. We are trained to do that. And in fact, what we should see as what is happening is that we are empowering the radiologist by giving the radiologist the means to access all these electronic tools to help the radiologist make a better diagnosis. Our biggest problem is that for whatever we do, the whole, what I would call the chain of production, from image acquisition to defining image contrast, to processing, to image interpretation, there is a lot of variation. We have different vendors, we have different protocols. Even in one hospital, and I know in Belgium, even in one hospital, in private hospitals, there are radiologists who are using different protocols. And they are all convinced that they are smarter than their colleagues and that they are more intelligent. Even for simple things like an MRI of the knee. One guy will use a TR of 2000 and another will use a TR of 1400 or whatever. We use different software and the interpretation is highly variable. I could give all of us here a data set to interpret and we could look at the results and we would have very variable interpretations. So we need standardization, and standardization is the key to this entire process towards developing biomarkers. Standardization means one important thing. It means you have to give up a little bit of your freedom. It means that you have to actually work in a group. You cannot be alone, and you have to be convinced that you have to do it the same that other people do. What is the future? Well, I think that the near future is this. When you go to your doctor, to your general practitioner, and he draws blood or she draws blood, the blood goes to a lab and they do a centrifuge and you get back a report with numbers. Your glucose is so much, your white blood cells are so much, your erythrocytes are so many, and all of this is numbers. We believe that for certain diseases, not for everything, but for certain diseases, we are going to evolve towards a kind of MR lab, that volumetric data will be fed into an analysis tool generating automated reports. And we strongly believe that this is happening now and that there will be no choice, because just as the European directive has decided that clinical decision support needs to be an essential part of the entire process, we believe that very shortly this kind of analysis methods will be an essential part of the entire process. Already now there's a number of diseases where we do this. I've shown you examples of MS, I've shown you examples of hippocampal volume measurements in dementia, but also, for example, in Parkinson's disease, you can look at diffusion-related abnormalities. You can look at abnormalities in the substantia nigra. We work a lot with brain trauma. We developed software to assess midline shift. We developed software to assess the number of lesions in susceptibility-weighted imaging. And there are many other diseases on the horizon. In my lifetime, when I was a child, my parents did not have a television set. But my grandparents had a television set and it was black and white. And I remember that when color TV came, it was very expensive. And I remember my grandfather saying, why would I need color TV? Because I can see everything I need in black and white. And I think we are going to face the same thing now with imaging analysis. The first reaction of many radiologists will be, why do we need all this? You know, we're perfectly happy as we are now. And all of this is going to be too complicated. I don't think so. I think this is going to change whether we like this or not. And with this, I would like to thank you once again for your time and your attention. Thank you very much. Raquel, do we have time? Okay. Would you like to see some cases? Okay. Vamos con la segunda presentación, por favor. Okay, so I call this case-based neuroradiology. And I would like to acknowledge my friends and colleagues from the University of Antwerp who have given me and shared some of their cases with me. Esta es mi primera pregunta. Which color is my country? Amarillo. Muy bien. So, eso es la Bélgica. As you can see, it's a very big country. And this is the detail, and Bélgica is divided in two parts. There is the north, and this is called Flanders, and this is the south, and this is called Wallonia, and La Capitale, Bruxelles, is like an island in Flanders. And my city is this city, which is close to a very big river. This is called Antwerp, in español es Amberes. La ciudad de Amberes es un puerto muy importante en Europa. Es el segundo puerto de Europa. And we say that we make the money in Antwerp and they spend the money in Brussels. This is, so my first question to you, this is a little bit more difficult. Of all of these things, which is not typical of my country? Number 3. And number 3 is typical of Holanda. Exactly. Beer, tenemos la mejor cerveza del mundo. Diamantes, Amberes es la capital mundial del comercio, del negocio de diamantes. Still today, there is a lot of competition more and more with Dubai and with Mumbai, but we are still number 1. This is the Atomium in Brussels. Chocolate Belge is very famous, and this is El Puerto, or just a very small part of the Puerto de Amberes. So I'm actually going to make you feel good about some cases, and then I'm also going to destroy your self-confidence. So this afternoon you will go to the beach and you will decide that you will never go back to radiology. And so I always give you a little clinical information. This is a 26-year-old man, not much of a clinical history. He has intermittent headaches, and clinical neurological examination is completely normal, okay? So I'm going to show you the images. T2, T1. Sin contraste, con contraste. ¿Dónde es la lesión? Pineal. Pineal, cisterna cuadrigémina. ¿Sí? So, there is a cystic lesion in the pineal region, the quadrigeminal plate. There's no edema. It is iso-intense to CSF, and there is no enhancement with contrast, as you can see here. Okay? So this is arachnoid cyst, right? Who agrees with me that this is an arachnoid cyst? Come on. Come on, come on. You know, I look like a nice guy, but I'm actually not. So what would you like to see? What did I not show you in all the images you saw? Diffusion. And I'm first going to show you flare. Is this an arachnoid cyst? No. It is a? Muy bien. Con restricción de difusión. So this is, in fact, what do you think? But you already said the diagnosis. This is a dermoid cyst or an epidermoid cyst, tricholemnal cyst. And this is from the literature and some images from the pathology. So this is like a very typical case, and it was an incidental finding, probably had nothing to do with the headaches of the patient. All right. This was easy, right? This is going to be a little bit more difficult. A 31-year-old woman, she is a nurse working in another hospital. Past medical history, she had a duodenal ulcer, otherwise unremarkable, and she had fainting spells since 1.5 years. Clinical neurological examination was negative, and an MRI of the brain was requested. So 31-year-old woman with, like a strange history. Don't say it's a maxillary sinusitis. That's not what we're looking at, okay? Where is the lesion? Intraaxial, extraaxial? Extraaxial. Restricción de difusión? Ideas? A strange looking lesion, huh? It's a very strange looking lesion. So what's your diagnosis? Epidermoid again? Huh? Who thinks it's an epidermoid? I have to tell you that in the beginning I thought it was an epidermoid, but I was wrong. Huh? A colloid cyst. Colloid cyst is typically found in the third ventricle, and I've never seen a colloid cyst in this location. It is mostly round. This is like polylobulated. Any other ideas? A meningioma, but it's very high signal, eh? And it has diffusion restriction. And yeah, it looks a little bit funny, huh, for a meningioma. So I tell you what this is. This is a neuroenteric cyst. Yeah. All the neuroradiologists there, you should have, yeah. But we never see that, right? It's very difficult. And this is from the literature. They typically live there in this typical location anterior to the brainstem because this is an embryologic remnant. This is from the literature. This is a very, very similar case. And the neurosurgeon took it out. It was like a pocket with liquid. He called me to come and see the operation. And they are lined by a sort of epithelium on the inside, and it's a columnar and cuboidal epithelium. Okay. This is good. 19-year-old man, no past medical history. This was actually a course, not just to make you feel bad, though. This was a case that we showed in Vienna at the junior film interpretation quiz. So they were not like you. Huh? So junior. So chronic muscle weakness in the left ring finger and in the little finger. So these two fingers, right? So no sensory abnormalities, no trauma, no neck pain, and normal lab. And I show you the images. This is an MR in flexion. So let's start here. What's the most important finding? A 19-year-old guy. What do you think of the spinal cord? It's there looks like atrophic, yeah? I don't know if it's segmental, but it looks like atrophic. What do you think of the spinal canal? It's big or small? Small spinal canal. So with medullary atrophy in a young man, it's not disc disease, right? It's no herniation. And here we see this. And then we do this MR in flexion. And what is this, what we see here behind? Exactly. And where are these flow voids? Anybody know the diagnosis? Yes?
Abnormal enlarged vessels.
Ye-
They only show up when you move.
Yep. You're on the right track. Okay, very good. But I need a name. Now you're moving away from the right track. So I give you a differential diagnosis, and you tell me what it is, okay? So is this ALS? Is this poliomyelitis? Is this a spinal cord infarct? Is this a neural compression, carpal tunnel syndrome, or a thoracic outlet syndrome? Or is this Hirayama disease? And this is, in fact, this is Hirayama disease, which is where the people believe, I'm not sure that I believe everything that they write in the literature, but they say that there is an imbalance between the growth of the vertebra and the dura mater, and you get a compression of the spinal cord against the posterior margin of the vertebra, and the compression affects the anterior spinal artery and causes microcirculatory disturbances with a sort of atrophy. And the key imaging findings are cord atrophy, and then the flexion study showing an increased posterior epidural space. So everything you said was right. Epidural space with a vertebral dural displacement. If you go to a quiz, it's like one of those typical quiz cases. But we have seen now, it is like everything. You know, once you know it, you start to see it. We have seen 2 cases in the past year, and they were always young individuals, and they always have this, you know, atrophy of the cord, and the idea is to think about it and then do the flexion study to look for these vascular abnormalities. Very good. 7-year-old boy. He was fine before, but since a couple of months, he has repeated episodes of headache and abdominal pain. And he had a subependymal bleed in the neonatal period, and a VP shunt was placed when the boy was 2 months old. This is at 5 months. You saw that he had massive hydrocephalus, and there was a VP shunt that was placed there. And now this boy is 7 years old, and we do an MR, and this is the MR. This is the magnified view. So you see here the rostrum and the genu of the corpus callosum are normal. And then it starts to get funny, yeah? And then the splenium is normal again. It's a very, very funny appearance. I had never seen that before. I show you the axials and coronals. You see here? There's something going on in the corpus callosum. Yeah, the ventricles have normalized. The ventricles have normalized. Good. I don't know where it is, but it's a good question. What? Excellent. Excellent, Raquel. Excellent. Excellent discussion. Now we need the name. So the differential diagnosis, well, it was this MS? No. The kid is too young. You don't get MS at 7 years. Ischemia infarcts, well, that's what you were saying. Venous thrombosis, a neoplasm. Was this Marchiafava-Bignami? No. And there is something that is known as corpus callosum impingement syndrome, which is due to the fact when there was the massive hydrocephalus, and I go back there, you can imagine here how the corpus callosum was compressed against the falx. And then you drain the ventricles, but if this has been long-standing, you get some damage to the corpus callosum. And this is known as corpus callosum impingement syndrome. Symptoms in this case most likely correlate to non-compliant ventricles with either VP malfunction. But the thing is, this is a complication of long-standing hydrocephalus. It is reported in the literature, but very rarely. And this, for me personally, was the first time that I ever saw this. And then you start to Google it and you find it. There's only a few cases reported in the literature. Good, this is a nice case. A 32-year-old man who is also a nurse working in a radiology department. And this is leading up to the next presentation of Professor Torres, so don't feel nervous, but you're the expert now. He suffers since several years from tinnitus, and he complains of hearing a high-pitched sound. And the interesting thing is when you talk to this guy, he says, "Doctor, when I do this," and he takes his thumbs and he pushes his thumbs behind his ears, he said, "I'm perfectly fine. And when I move them, I hear it again." Yeah? So crazy, right? Loco. Completely loco. But then we do the CT, and I'm going to show you a few examples. And once you know what it is, you tell me, right? The first prize is a trip to the Caribbean, to Cancun. It's very cheap because you're already there, so I don't actually have to give you anything. So this is a CT with contrast. Just look at what is outside the skull here. You see that? Look at this. Have you ever seen something like this? So you can understand that when he pushes with his thumb behind his ear, he's actually compressing these blood vessels. And this is the inside. Now I have a multiple choice. What's your diagnosis? Is this an aggressive meningioma? Is this a superior sagittal sinus thrombosis? Is this a cerebral arteriovenous malformation? Or is this a dural arteriovenous fistula? Yeah. And this is actually fantastic. Yeah? It's a massive, massive dural arteriovenous fistula. The guy has been living with that problem for years. And he's always told his doctors, including his general practitioner, and he loves to demonstrate this because he knows that he can alleviate the symptoms when he does that. So a massive dural arteriovenous fistula. Okay, we're going to finish up with, and I'm not going to read through the slide. We're going to have two cases which I say are typical Belgian cases. Yeah? Tipicamento Belgica. Por varonas belgas. Varones belgas, yeah? Varones. A 54-year-old man was admitted to the hospital because his vision progressively deteriorated. He became confused and he was unsteady on his feet. Neurologic examination revealed involuntary eye movements in all directions and a marked gait ataxia. He has a history of alcohol, and he's known to have an enlarged steatotic liver and gallstones. So you can picture the guy. He's 54 years old. He's walking like this, and you see his eyes. They are moving all over the place, yeah? And this is the T1, showing for the age some atrophy. T2. Flare. On the flare, you should pick up something interesting. Le corpora mammillaria. They are hypersignal here. Very good. On diffusion-weighted imaging, the ADC maps, difficult to see because it's too small. And then we give contrast. And you see anything enhancing? There is enhancement, and enhancement means disruption of the BBB. And here you see it on the coronal images, and here a magnified sagittal. So what is this? Very good. This is Wernicke encephalopathy, and Wernicke encephalopathy is caused by a deficit of thiamine, and you see these hyperintense lesions on the flare, and you see the enhancement, and you see this. When I was in the beginning of my career, we had a professor of neurology who was a brilliant neuropathologist, and every Friday we had the brain cutting, and it was like una mesa sacral, the brain cutting. Everybody was, and he would always take the brain and first turn the brain over and look at the mammillary bodies. And he said, the mammillary bodies are small. I think this was a guy who loved to drink. Or the mammillary bodies are big. This was a good guy. So this is where we learned, and this is Wernicke. And when you look at it from an embryologic point of view, Wernicke encephalopathy is a disease of which part, which embryologic part of the brain? It's a disease of the diencephalon. Diencephalic disease. And the diencephalon, apparently, there are different cells with different receptors, and this is why you get this. Last case, 58-year-old man. Again, admitted to the emergency room after a prolonged status epilepticus. Past medical history, alcoholic liver cirrhosis. I told you Belgium has la mejor cerveza del mundo. It's true. I had a liver transplantation 1.5 years ago, and we performed an MRI of the brain. You see this? With some diffusion restriction there. So what is this? More or less the same question that I asked you for the previous case. This is typical, this subinsular, this involvement here of the insular cortex here is typical for hepatic encephalopathy. This is hyperammonemia. And this is typical, and we see this quite a lot. My clock says that my time is up, so I would like to thank you very much for your collaboration. Thank you.
¿Algunas preguntas para el profesor Parissel? ¿No? ¿No hay preguntas?